So our objective today is to discuss the question of how we should practically monitor our patients during surveillance. Okay, so I have no disclosure. So our objectives for this morning are to first and foremost understand the rationale for active monitoring during surveillance. 2, to review and address the consensus elements among the numerous defined surveillance protocols. 3, to evaluate risk-adapted approaches to surveillance. Also examine the evidence supporting serial imaging during active surveillance. And close by addressing some of the future directions and enterprises, including biomarkers and genomic testing during surveillance. So I want to begin with saying that active surveillance is in prime time. It's safe to say in 2017 this is where we stand. These are the Cancer Care Ontario guidelines published in JCO, indicating that for most low-risk Gleason 6 patients, active surveillance is the recommended management strategy. This is not a fringe management behavior that's done at academic institutions. This is really becoming the standard of care. There are some caveats for younger men, African American patients, and those with high volume disease. And if you look at the trends nationally in the United States, this is data from the Capture registry. Surveillance has really taken a big spike. So this is data published from Matt Cooperberg and Peter Carroll last year. But the utilization of surveillance is up near 40% nationally. I think we have a ways to go, and we are probably going to continue to see an increase, but we're officially in prime time here. And people are taking notice. This was a headline in the New York Times back in May saying that more men with early prostate cancer are choosing to avoid treatment. So this has really clearly gathered the attention of not only academically, but among our patients as well. So why offer surveillance? Well, our aim is to balance the immediate risks of overtreatment by selecting patients with low-risk features and monitor them closely over time to afford definitive treatment if compelling disease is detected. So we start with initial risk classification using clinical variables, PSA, Gleason score, tumor volume, age, other characteristics, perhaps integrate new tools as well, and essentially provide a circle of risk assessment of periodically over time to make a decision. Who is a candidate? So there are many surveillance protocols that are published. The details are probably less important. Some classifications have more restrictive criteria, patients only with Gleason 3-3, low volume, low PSA density. I think the Hopkins criteria is probably most illustrative of that. And if you look at other series, including Toronto, they do include patients with slightly higher PSAs, some patients with Gleason 3-4 low volume tumors. So if you look in the broad strokes, who is a candidate? These are patients with an extended pattern biopsy, perhaps MR targeted. They should have low-grade disease, so no primary pattern 4 or pattern 5. They should also have low volume of disease, less than 50% of a single core, less than a third of course positive, but there is some wiggle room here between the different institutions at how we define that. Serum PSA should be low and stable. Lower PSA density is also quite favorable, and low clinical stage. I think some two considerations that keep coming up time and time again are the role of patient age. Are younger patients candidates for surveillance? And what is the role of race and ethnicity? Are African American patients candidates for surveillance as well? So first, if low-grade disease is truly biologically indolent, why even monitor at all? So I think the rationale comes from two locations. Number one, there is indeed a risk of initial disease undergrading and understaging. This is data from the UCSF cohort showing the risk of biopsy upgrade over time. So 21% of patients on their first biopsy upgraded, and that risk persisted 22% on the second biopsy, 30% on the third biopsy. So as we keep crossing over time, we begin to see a second force, and I think that's the specter of disease progression over time, the risk and the genuine concern that a truly low-grade disease might progress to higher grade elements. We're also learning lessons in the context of the maturation of large randomized trials. Notably, this is the PROTECT study, which is really a remarkable study that was published in the New England Journal of Medicine earlier this year, looking at a randomized study from centers in Europe which followed patients for 10 years. And so 1,545 patients were randomized to receive active monitoring radical prostatectomy or radiation. The surveillance protocol, I think, is notable to mention how patients were followed. So it's a little different from how we might do things today, but patients had their PSA monitored every 3 months in the first year and then every 6 to 12 months. So this is largely a PSA-based surveillance protocol. But increases of 50% in PSA would trigger review and potentially treatment, but a periodic biopsy was not mandated. And it's interesting, if you look at the curve here, about 56% of patients who were initially assigned to surveillance ultimately did receive treatment, so there was crossover to treatment in this group. But this is really a striking figure which sort of takes home the point of how do patients with Gleason 6 prostate cancer do. And it's essentially a flat line. It's really remarkable when you see that the prostate cancer specific survival was almost 100% no matter how you cut it, if you had surgery, radiotherapy, or were initially assigned to active monitoring. So this seems like a real success story for any strategy. But there is genuine cause for concern, I think, if you look at more proximate endpoints, not cancer-specific survival, but some of the earlier endpoints, risk of disease progression and metastatic disease. And there were differences in the patients who were monitored. So almost a twofold greater risk of metastatic progression as well as overall disease progression. And the rationale for monitoring appears to emerge from the fact that perhaps there are patients with higher grade disease who could be culled out if we observe them a little more carefully, do repeat biopsies, and find evidence of higher grade elements. So what are our goals here? And what I offer essentially is that our goal fundamentally is to strike a balance that minimizes the burden of diagnostic procedures while preserving oncologic efficacy. So we're really sort of walking a tightrope here, and we're trying to tip the scales, really keep them even between more surveillance, higher intensity versus less intense surveillance protocols. And I think the rationale for this comes from several factors, that doing repeat biopsies is not without complication. This is data from the Prius study in Europe, looking at over 2,100 biopsies in 1,100 men. And about a quarter of patients experienced one or more biopsy-related complications, hematuria, hematospermia, pain, or infection. And 2.5% experienced sepsis. So unsurprisingly, among the patients who experienced the complication, they were less likely to undergo a subsequent biopsy. So it really drives home the point that there are complications with doing repeat biopsies, so that's why we're not doing them time and time and time again. And if you poll patients as to why they discontinue surveillance, they offer various reasons. And this is data from Stacy Loeb, from patients citing the reasons for discontinuing surveillance in the Swedish National Prostate Cancer Registry. So the reasons offered are changes in PSA kinetics, progression seen on biopsy, change in Gleason score, number of course positive, or tumor volume, as well as patient anxiety. So patients' anxiety does drive quite a bit of this. So if we surveil more intensely, that means more biopsies, potentially more toxicity. There are considerations of cost, and also more opportunities for detection and progression of perhaps clinically insignificant disease which might trigger treatment. If we tip it the other way and we are less intense, we face a potential risk of progression, missed opportunities for cure, as well as anxiety at the lingering specter of disease progression. So is there a consensus about how surveillance should occur? And like anything else, I think in medicine, if you ask two different people, you'll get two different answers. And so this is just a summary of the national active surveillance guidelines. These are national guidelines, not even institutional. And there's really remarkable range in how protocols exist, some including very formal recommendations about how often we should biopsy, how much we should include MRI as well. But if we break down some of the more specific guidelines, and this is the 2017 NCCN guidelines on prostate cancer, looking at the very low and low NCCN risk groups, they offer the following recommendations: that a PSA should be performed no more than every 6 months unless clinically indicated, digital rectal examination no more than every 12 months, repeat biopsy no more than yearly, and it begins to enter the consideration of multiparametric MRI if we suspect an anterior or aggressive lesion that might be seen in the context of PSA increases or when a systematic biopsy is negative. They highlight that PSA density and PSA kinetics are less reliable indicators of progression as well, so we're de-emphasizing those. If you look at the European guidelines, the EUA guidelines, a little less committal about this, that follow-up should be based on repeat biopsy, serial PSA, and DRE, essentially offering a little more interpretation for a patient's perceived risk, noting that the optimal biopsy regimen is still today unclear. And as of yet, multiparametric MRI cannot replace follow-up biopsies and should not alone be used as an assessment tool to prompt active treatment. In the Cancer Care Ontario guidelines, which I think struck a nice balance here, they dictate that the PSA could be performed every 3 to 6 months, digital rectal examination at least every year, and at least a 12-core confirmatory biopsy with anterior-directed cores within 6 to 12 months, then serially every 2 to 5 years, so really spacing it out quite a bit more if clinically warranted. And they do offer, again, some discussion of the inclusion of ancillary tests such as multiparametric MRI and genomic testing. So those are the broad guideline panels, but if we look at some institutional protocols, in Toronto, PSA at 3-month intervals for 2 years and then every 6 months, a confirmatory biopsy within 12 months, and then every 3 to 4 years until the age of 80. At UCSF, we were doing PSA every 3 months for 2 years and then at 6-month intervals, and confirmatory biopsy at 12 to 24 months as dictated by perceived disease trajectory. The use of imaging also quite variable. In the Prius protocol, MRI is sort of a plus or minus recommendation to rule out anterior tumors. At UCSF, all patients were now routinely undergoing prospective evaluation with multiparametric MRI. And in the Hopkins cohort, MRI is not explicitly required for inclusion. Some of the other questions that we evaluate is the role of PSA kinetics. And this question really comes back and forth quite a bit in terms of the role of it, and there's always sort of some back and forth about this. In the Hopkins data, PSA kinetics after diagnosis have not really proven to be a robust predictor of surveillance. So if you look at patients who progressed, PSA velocity and PSA doubling time were not significantly associated with those outcomes. And so we're really de-emphasizing that as a predictor of who is at higher risk for progression. So just to summarize some of the consensus elements, I think it's important to emphasize that many surveillance protocols exist. The common elements, though, that are upheld by guideline bodies and landmark institutional cohorts include PSA and digital rectal examination semi-annually, a confirmatory and extended sextant biopsy at variable intervals, anywhere from a year to every 3 to 4 years. But I think the winds are blowing in the direction of spacing these out more and more. There's an increasing attention towards MRI. However, it's not mandated by any major guideline or institutional protocol as of today. That's probably changing. I think we're leaning in that direction. And lastly, that PSA kinetics do not appear to reliably predict the risk of progression on biopsy. So the natural question is can we tailor our surveillance protocols by predicting who is at a higher risk? Clearly, not all patients are the same. A patient who has a 3-4 tumor and a more questionable PSA is different from someone who has a microfocus of Gleason 3+3. So if you look at which clinical variables predict progression over time, there are a few that are sort of reliably conserved in institutional protocols. And this is data from UCSF looking at risk of progression over time. And the two significant variables were PSA density and the status of the confirmatory biopsy. So if you had a negative confirmatory biopsy, you almost had a 4-fold decreased risk of experiencing progression. And I think if you think, why might that be? Well, it probably reflects a few forces. Number one, the population of patients undergoing surveillance is really quite homogeneous. These are patients with low-grade tumors, low-stage tumors, and low PSA. So we're not going to just be able to detect significant differences there. PSA density and confirmatory biopsy status essentially offer new prognostic information which we can mobilize. And then there's the question of age. Now, historically, younger patients have been dissuaded from engaging in surveillance for several reasons. Number one, oncologic concerns of disease progression. Two, the perception of a longitudinal burden of follow-up, which might be too much to bear. But if you think about it, patients who are young really have the most to lose. They have higher levels of sexual functioning, better urinary control, and so I think a policy of immediate treatment for all young patients requires some greater scrutiny. So this is data from UCSF, which is in press, looking at the role of patient age on outcome during surveillance. So this is a data set of 1,400 patients, and interestingly, younger patient age was independently associated with a decreased risk of biopsy progression. And that's stratified at 60 years, but also exists on a continuous basis. And so this is not really, even though this is newly published, data has been really presented almost in every single institutional cohort with an effect of younger patient age being a protective force. And it's important to note that even though younger patients had a decreased risk of biopsy progression despite having more frequent biopsies. So younger patients are surveilled empirically more closely, but despite that, had lower risk of progression. So if we look to try to refine how we assess risk in these patients, the other variables that were significant in addition to patient age are PSA density, the total number of biopsies. So basically, the harder you look, the more likely you are to find something. The other question is, does reclassification exist as a dichotomous event? Right? So historically, we talk about reclassification as any one change in a variable, and that tips you off the scale for surveillance, that you're not an appropriate candidate. So in order to examine whether or not reclassification might exist on a dynamic scale, we looked at this question again in the UCSF biopsy cohort and looked to see how much risk, when looked at comprehensively, changes over time. So we looked at the Capra score, and I mentioned the Capra score yesterday as a 0 to 10 continuous assessment scale of risk. So points are assigned for Gleason score, for PSA, for percentage of course positive, age, and digital rectal examination. So it offers really a holistic expression of patient risk. It's interesting that people really, the distribution is all over the place. So most patients do not change in risk status. Actually, a fair number of patients go down. 8.2% had a decrease of 1 point in their Capra score, almost 2% by 2 points. 18% had a negative confirmatory biopsy. But if you look on the right-hand side, there are patients who experience greater magnitudes of risk change. And perhaps we can substratify the risk of an adverse event even among patients who reclassify. So we looked at the magnitude of risk change. So how much does your Capra score change, and is that predictive of adverse event? So the outcome here was having adverse pathology at surgery, so primary grade Gleason pattern 4, or locally advanced disease T3 or higher, or positive lymph nodes. And so unit changes in the Capra score were independently associated with the risk of adverse pathology, suggesting that even in a patient who reclassifies, who changes by one variable, we can get a little deeper and look a little deeper under the surface to see how their entire risk picture changes, and use that to potentially offer intervention. I think in 2017, I would be remiss to talk about surveillance protocols and not mention multiparametric MRI. So undoubtedly, the MRI revolution has changed surveillance in the United States, decreasing initial understaging potentially resulting in greater comfort in surveillance. And this is a real patient who had a Gleason 3+3 tumor who was on surveillance, who had a PSA of 8.4, and who underwent a multiparametric MRI and was found to have an infiltrative central gland lesion, which was identified on biopsy as a pattern 4+4 and was ultimately treated. And so these are the lovely anecdotal experiences that everyone shows that indicates that MRI is essentially calling out these high-risk, dangerous lesions. But there are, I think, some important remaining questions which in the space of surveillance, and they're really as follows. What is the yield of multiparametric MRI in patients on surveillance? Most of the data we have are patients who do not have a diagnosis of prostate cancer. So among men who already have a positive biopsy that's low risk, low-grade disease, what is the increased added value in doing a multiparametric MRI? Secondly, is MRI required in all patients? And I'll disclose that I don't know. That's my frank assessment. How often should MRI be performed in surveillance? And is a change in imaging a reliable reflection of disease progression in and of itself? This is data from UCSF looking at patients who were diagnosed on systematic biopsy with Gleason 3-3 disease who underwent an MR fusion biopsy during surveillance. Now keep in mind, the only way you get an MRI fusion biopsy is if you have an MR apparent lesion. So this does not include patients who have low suspicion MRIs, but these are patients who have something which is deemed above a threshold, and we use the PIRAD score, patients who have a PIRADS 3 or higher score. So the inclusion of MRI-directed cores resulted in upgrade in 17% of patients, 22% on systematic biopsy alone, and 2% on both MR and systematic biopsy. So this, I think this was fairly compelling evidence to us. There is an additional yield at detecting high-grade disease, and not just small incremental changes, but about 5% of patients who had a major upgrade, detection of Gleason pattern 4+3 or higher. The second question is, so if you've done your first MRI fusion biopsy, if you've bought into that, now do we need to do an MRI fusion biopsy in every single patient on serial imaging, right? So you've had your first MRI fusion biopsy. Is it sufficient to do systematic biopsies thereafter, or do you need to do an MRI fusion biopsy? So this is data from the NCI looking at their really remarkable cohort of patients who've been followed over time. This is 166 patients who underwent repeat MRI fusion biopsy. This was just published last month. They defined progression, I think, in a fairly comfortable way, which is any change in Gleason scores. If you went from a 3-3 to a 3-4 or a 3-4 to a 4-3, that was a change. And they highlight, one patient in particular. This is their first MRI. You can see an abnormality in the right peripheral zone. And on repeat MRI 15 months later, it's clearly much more concerning in character. This was biopsied, and the patient experienced an upgrade. So among the 166 patients, 30% of them upgraded on their second fusion biopsy. And interestingly, so more patients upgraded in the targeted cores, but 30% of the patients who upgraded did so on systematic biopsy. And the only risk factor for upgrade on biopsy was MRI progression. And so we define that by really three different things. There's a change in the suspicion score, the overall suspicion of the MRI, an increase in lesion diameter, does the lesion get bigger, or the appearance of a new lesion. So among the subset of patients who had all three characteristics, so if you had changes in the suspicion score, the lesion diameter, and the appearance of a new lesion, 100% of those patients experienced progression. And less so for patients who had 2, 1, and the lowest risk category would be 0. And so I think that data really indicates that there is additional yield of doing an MRI fusion biopsy even when a patient has initially been sampled, but we cannot throw out the systematic biopsy cores, which I think is the holy grail that people have been interested in just targeting that lesion. There is a third of patients who upgrade outside of that target, so we can't forget that. We heard an excellent overview of some of the novel PSA isoforms yesterday by Dr. Stone, and there was a great question yesterday about how we should integrate, or whether we should integrate those new isoforms in surveillance, and do they predict outcome? And this is data just published from Dan Lin in the Canary Pass cohort, looking at the predictive ability of the 4 kallikrein panel among patients on surveillance. So they looked at 718 patients who were followed serially over time. And interestingly, and as you might expect, so the 4K score was significantly associated with biopsy reclassification on the confirmatory biopsy. So these are patients who had one biopsy, they were enrolled in surveillance, and if you had a higher 4K score, you were more likely to upgrade on your confirmatory biopsy. But it did not add any predictive value to the base model for predicting upgrade at subsequent biopsy. So I think the take-home message here is it's good at helping you cull out the disease that's missed on biopsy, but it's not giving you a lot of biologic information about the risk of disease progression over time. So we seem to be ratcheting up the intensity at which we're looking. And so the question arises, should we be doing, if we're doing serial biopsies, should we be doing serial genomic testing on that tissue that we have? And will it be meaningful? I discussed this yesterday briefly about the role of genomic testing at initial diagnosis and making considerations for who might be a candidate for surveillance. We discussed that genomic tests might appear to substratify risk among clinical risk categories by offering some additional genomic information. So we looked at this question among patients at UCSF who had repeat genomic testing on biopsies. And these were really a combination of patients who were part of a pilot study with the company, as well as patients who were essentially just having it empirically through clinical practice. So there were patients here who were matched to biopsy Gleason score. We looked at patients whose Gleason score stayed the same, and we wanted to see if your Gleason score stays the same on serial biopsy, are you likely to have a change in your genomic score? And we also looked at patients who had an upgrade in their biopsy. So if you went from a 3.3 to a 3.4, did your genomic score also change? And I think that really speaks to one of the questions we had yesterday about tumor sampling, right? So is a 3.3 in the same prostate the same as a 3.4 that's next door? And I think that's really a very significant question. So interestingly, the mean change in the GPS score is really not that significant. It was 3.4 points, and that's on a scale of 100. And that was for patients who did not progress. And for patients who did progress, it was actually even lower. So these genomic scores appear to be pretty flat, even if you progress or if you don't progress. So I think that's fairly interesting information, which potentially has implications for how often we sample these. We do this repeat genomic assessment on serial biopsy. And then I think there's the subsequent question as well to kind of bring things home and synthesize. Now we have two competing spaces. We have imaging, which we think is giving us refined information. We have genomics, which might be giving us refined information as well. Well, how do these overlap? So we looked at patients, 100 patients who had both MRI and genomic testing during surveillance. And interestingly, we saw sort of a wide distribution of genomic scores, even in patients with positive MRI findings. So patients who had a PIRAD scores of 4 or 5 were essentially combined together, and there's really a big distribution, which you don't see in patients with a negative MRI. So this might indicate that the MRI is offering some biologic information. It might give us some insight for how we sequence these. If a patient has a negative MRI, a very reassuring MRI, perhaps they don't derive much benefit from additional genomic profiling. And I think we could sort of, logically group them together, that patients with negative MRIs might be distinct from patients with intermediate or positive suspicion scores. So I want to close there and just offer some concluding thoughts. First and foremost, close observation during surveillance offers opportunities for detection to preserve windows of cure for our patients. There's no singular consensus regarding how we should monitor, but I think there are some elements which are certainly hold true among all, including serial PSA testing, digital rectal examination, confirmatory and subsequent biopsy at some interval. MRI fusion biopsy appears to detect a higher proportion of cancers versus systematic biopsy. However, targeted biopsy alone would be inadequate. There's an interest in new PSA isoform testing, which appears to be predictive of confirmatory biopsy status, but not beyond that. And in the future, I think our sights are set more on a personalized approaches to risk stratifying patients and assessing their individual disease trajectories in defining how intensely we monitor them during surveillance. Thank you very much.